This presentation is going to focus on the techniques of physical assessment. After this presentation, you should be able to discuss the purposes of physical assessment. You should be able to list the 5 techniques utilized in assessment and state the proper order of assessment techniques in every system but abdominal. Then be able to state the proper order of assessment techniques for the abdominal assessment. I'd like you to be able to demonstrate the techniques used with each physical assessment and distinguish between the sounds best heard with the bell of the stethoscope and the sounds best heard with the diaphragm of the stethoscope. Health assessment and physical exam are going to be important skills for you to master because health assessment and physical exam help us to provide safe, competent nursing care. These expert skills help nurses determine the client's health status. They help us distinguish variations from the norm. They also help us recognize improvements in our client's status, which is always a good thing. But most importantly, assessment skills are going to help you identify deterioration in your client's status. This presentation is going to focus on the techniques utilized in physical exam, which is also referred to as the physical assessment, because performing these techniques correctly will be foundational to your success in this course and your nursing career. You will be learning more about health assessment throughout this semester. The 4 techniques utilized in physical assessment are inspection, palpation, percussion, and auscultation. These techniques are performed one at a time in order for every system except abdominal, and I'm going to go over the abdominal assessment towards the end of this presentation. Inquiry is another method utilized during assessment, but we don't really list it in a specific order because inquiry is something that you're going to be doing throughout your assessment. As you go to the different body systems, there'll be questions you want to ask your client about. And a little phrase that I use that helps me remember the proper order of assessment is, I palpate perfectly, amen. So let's talk about inspection first, since it's the first technique. Inspection involves looking, listening, and smelling. You start the assessment of each body system with inspection. You will look at each area to be assessed. And when I'm talking about listening here, I'm talking about you're listening to what the client is telling you. We're going to talk about listening to body sounds a little bit later in this presentation. Nurses also need to have a keen sense of smell because odors can tell you a lot about a client's health status. We inspect each area for color, size, shape, symmetry, position. We look for abnormalities, and as I've mentioned, we also detect odors. I want to point out that we always check for side-to-side symmetry by comparing each area with its match on the opposite side of the body. And that's going to be a very important concept for you to understand this semester. And sometimes the words observe, note, or assessed are used interchangeably with the term inspection. The next technique utilized in physical assessment is palpation. And palpation involves using our touch to gather information. So before you touch the patient, you're always going to want to warm your hands first. You pay close attention to areas that are painful or tender, and you palpate those areas last. 2 types of palpation that we're going to be using this semester are light palpation, and that's when you press inward about 1/2 inch. And then deep palpation, you press inward about 2 inches. You may also sometimes, when you're performing palpation, use a bimanual approach. And this means you relax one hand on the skin and the other hand helps to apply pressure to the sensing hand. And we're going to go over this during the abdominal assessment. Percussion is the next method we utilize in physical assessment. And it involves tapping the skin with the fingernails to vibrate the underlying tissues and organs. Because tapping on the skin produces sounds that help us assess the underlying structure. The denser the tissue, the quieter the sound. I'll say that again. The denser the tissue, the quieter the sound. The sounds are made with the middle finger of one hand tapping on the middle finger of the other hand using a swift wrist action. And we're going to demonstrate this for you in Fundamentals Lab. What is really important today is for you to know the definition of percussion and the sounds produced by percussion. So let's review the percussion sounds. You will detect resonant sounds, which are low-pitched, hollow sounds over normal lung tissue. Keep in mind that dullness will replace resonance when the fluid or solid tissue replaces the air-containing lung tissues, which occurs in conditions such as pneumonia, pleural effusions, or tumors. You'll detect flat or extremely dull sounds over areas such as bones. Dull sounds are normally heard over dense areas such as the heart or the liver. You'll detect hyperresonant sounds, which are a little bit louder and lower pitched than resonant sounds, and they're normally heard when percussioning the chests of children and very thin adults. But keep in mind, when you hear hyperresonant sounds, that means the lungs are hyperinflated with air, which may occur in patients with COPD or patients that are having an acute asthma attack. Tympanic sounds are hollow, high, drum-like sounds. And tympany is normally heard over the stomach and abdomen, and we'll be talking about this during the abdominal assessment. Lastly, the last technique utilized in physical assessment is auscultation. And auscultation involves listening to the sounds produced by the body for presence and quality. Usually we use a stethoscope to listen, but sometimes the body can make noises that we can hear without a stethoscope. We do need the stethoscope to hear internal body sounds, and the ear tips should be forward. And we're going to assemble our stethoscopes the first day in Fundamentals Lab, and we'll be going over how to use the stethoscope during lab. What's going to be important for you to know today is that the diaphragm is used to listen to higher frequency sounds, such as heart sounds, lung sounds, and bowel sounds. And the bowel side is used for hearing low frequency sounds, such as murmurs, bruits, and extra heart sounds. And when you use the bell, you only use very light pressure, because if you apply firm pressure when you're using the bell, it makes the bell act as a diaphragm. But it would be beneficial for you today to memorize the sounds you will hear using the diaphragm and the bell of your stethoscope. Let's go over the order of abdominal assessment, because it is different than the other areas of the body. You're going to inspect like you would other areas of the body first, but auscultation is done before touching the abdomen, because touching the abdomen before you listen may stimulate activity in the abdomen, which will falsely increase your bowel sounds. Percussion helps relax the muscles of the abdomen, which is the reason it is done before palpation. And the term I use to remember the proper order of abdominal assessment is I am perfect pal. When inspecting the abdomen, you're going to look at the abdomen for two different angles, and that's to determine if the abdomen is symmetrical. We in nursing love when we assess and things are symmetrical or equal bilaterally. We love that, okay, because that's usually a normal finding. Now, the abdomen can be described as flat, round, or obese, or concave. Another word for that is scaphoid, okay? So if it's concave or scaphoid, that could mean they're malnourished, or maybe they're just thin naturally. We want to know if the abdominal inspection is symmetrical. I talked about that. We want to note if it's distended. So the abdomen can be distended because of gas, or they could have a tumor somewhere. You might notice hernias on the abdomen. So that's why we inspect that. You would also inspect the color of the abdomen, if there's any veins, lesions, scars, the hair distribution, and what the umbilicus looks like. Okay, it should be midline, it should be not protruding and or flat and concave. And the color of the abdomen should be consistent with the rest of the body. Here is an example of hernias you may see. Hernias are usually named by their location, and I know that sometimes ATI has them as hotspots on exams. So, for example, just remember the femoral is lower than the inguinal hernia. People can have umbilical hernias, they can have hernias at their surgical incision, epigastric, all kinds of hernias that you would be inspecting for. You can auscultate using the diaphragm of your stethoscope in all four quadrants. And we're listening for bowel sounds because those are the sounds that are created by peristalsis, which peristalsis is the sounds the bowels make when they're moving, okay? So start in the lower right quadrant. The reason we start there is because that's where the ileocecal valve is located. The ileocecal valve is where the small intestine meets the large intestine, and that is where the bowel sounds are going to be the loudest, okay? So start there, and you're going to listen in all four quadrants. Once you hear the bowel sounds in a quadrant, you can move on. But if you do not hear vowel sounds in a quadrant before you can say they're absent, you have to listen for 5 minutes. Okay, so just remember that. You're listening to vowel sounds to determine if they're present, number one, but what's the quality? So normal vowel sounds, you're going to hear like high-pitched gurgling sounds every 5 to 15 seconds at a rate of 5 to 34 times a minute, right? That is normal. Hypoactive are less than normal because maybe it takes like 30 seconds of listening before you hear a vowel sound, and they're infrequent. Okay, a borborygmi is a term meaning hyperactive vowel sounds, so they're loud and prolonged. They may be normal if you're hungry, but they also can indicate gastroenteritis and an early intestinal obstruction. Okay, so you got to watch those. If you hear high-pitched tinkling sounds, that indicates early obstruction, bowel obstruction. To palpate organs for size, shape, or to determine tenderness, or if there's any abnormal masses, we use the entire palmar surface of our hand or the palmar surface of the fingers. So let's just review the 4 techniques again during abdominal assessment. The techniques are inspection, auscultation, percussion, and palpation. All the other body systems you will inspect, then palpate, percuss, and then auscultate. If you're going to do a bedside assessment, before you do a bedside assessment, you want to check the client's history. Hopefully you've had a really in-depth report. You want to note if they're on any isolation precautions because you want to be ready when you go to the room. You're going to assess if they have any latex or any other type of allergies that you need to know about. And you also need to know if the patient is on fall precautions. When you enter the patient's room, you're going to perform what's called an AIDIT. So AIDIT is a mnemonic that is used for introducing yourself and when you meet new patients, okay? So the first thing you want to do is acknowledge your patient. And I always do this using Mrs. or Mr., unless I know they're a doctor or something. I never use first names unless they invite me to use their first name. And then you're going to introduce yourself. Hello, my name is Miss Cohen, and I have been a nurse for 37 years, and I'm going to take very good care of you. That's an example of how to introduce yourself. Duration, you're going to say, I'm going to be with you here until whatever time you're working to, and I'm going to do a physical assessment on you right now, and this is going to take about 10 minutes. And then you explain the reasoning why you want to do a physical assessment. And then at the end of the session, after you do perform your bedside assessment, you want to say thank you to the patient. Before you start any type of exam, you always want to do a pain assessment on the patient. You can use the PQRST framework for assessing pain. So the first P is like provocation, and it also can mean palliative, like what makes the pain worse, what makes the pain better. What is the quality of the pain? Is it sharp, dull, burning, etc.? You want to ask the region, where is the pain located? Does it move anywhere? Does a change in position change the pain? Severity of pain on a scale of 0 to 10, with 10 being the worst pain. And then timing, when does the pain occur? How long does it last? Okay. Now, the reason you want to do a pain assessment is because if your patient is having pain, they're probably not going to participate in the assessment. They're not going to be in the mood. And so you may have to medicate PRN before you do any type of assessment. Then you want to wash your hands in front of the patient before you begin any type of assessment on them. You want to note your patient or clients, I should say, general appearance. For example, what's their facial expressions like? Are they appropriate to the situation? You want to know what their body position is like. Are they relaxed and comfortable, or are they tense and in pain? What is their LOC? Are they alert and oriented? Are they attentive to your questions? Do they respond appropriately? Do they know what their name is, their birth date? Do they know what date it is? Now, people in the hospital do lose track of time, and that is a normal finding. Just keep that in mind. You want to assess their skin color just when you're looking at them. Okay, I'm not talking about doing a full in-depth inspection of the skin, but just note their skin. Is it pale? Is it ruddy? Is it cyanotic? And then nutritional status. Does their weight appear in a healthy range? Do they look malnourished? Are they obese? Okay, you want to look and see if the hydration status looks good. This is just an overall general appearance. You want to assess if their speech is clear and fluent, and if they're appropriate, their responses are appropriate to what you're asking them. Hearing. You want to know if they can hear well, and you can try to assess that by the responses to your questions and their facial expressions. And also the last thing I forgot about is personal hygiene. Do they look like they're combing their hair, brushing their teeth, etc.? Some people who are really sick may not be able to, so that's something you would assess for. Next, you measure the vital signs, the temperature, the pulse, the respiratory rate, BP, and pulse ox. What you want to do is assess whether the vital signs are on trend for that patient, meaning they're in the same range, or if they're higher or lower for what has been trending in the patient since that time. You also would redo a pain scale if you medicated the patient. So if you gave an IV medication, you can reassess again in 15 minutes. And then if you did PO medication, it would take about an hour for that to work. So you always want to evaluate after you give medication to see if it worked. All right, with the neurological system, you've already done the LOC in your general appearance. And then you want to know, like when you walk in the room, did the eyes open spontaneously? Are their motor responses strong and equal bilaterally? Are the hand grafts and foot pushes equal bilaterally? You want to note the pupil size in millimeters and the reaction to light. Is it brisk or sluggish? Are the pupils equal and reactive to light? You want to determine if the patient has atosis. Atosis is eyelid lagging. So as people age, it is normal for their eyelids to lag. So if you see it bilaterally, that's probably a normal finding in an older adult. If you only have one eyelid that is lagging, that could mean a neurological problem. Okay, so you would note that. And you want to know if your patient can swallow. If you have a patient that came in with neurological problems, you wouldn't allow them to drink anything until they were assessed for their ability to swallow. You want to inspect the chest wall. One of the most common deformities in the chest wall is something called a barrel chest. And this happens because if the lungs become chronically overinflated, like in chronic obstructive pulmonary disease, which is very prevalent. Okay, and it means that the anterior and posterior diameter of the chest has expanded and it looks more like a barrel than a normal chest. Okay, in health promotion and disease prevention, we do screen for spinal curvature disorders. So what you would do is during the physical exam is instruct the patient to bend at the waist and let their arms dangle towards their toes, like they're reaching for their toes. Inspect and palpate down the spine with a thumb and finger. What you're looking for is you want the spine to be midline and you want them to have no tenderness in the spinal vertebrae. Okay, and then inspect and palpate with the client standing. So you do it while they're bent over and while they're standing. So the normal spine you can see has a distinct curvature. And then lordosis is also known as sway back. And this would be like normal in like pregnant people. You know how you kind of waddle at the end when you're pregnant? Um, Kyphosis. I would expect kyphosis on an older adult, and you can see it's like a hunchback, right? And then scoliosis, we screen teenagers for this, our adolescents, I should say. And this is a curvature of the spine. It's a sideways curvature. So it's sometimes an S shape. So it makes it easy to remember what scoliosis is because it begins with the letter S. When we palpate the thorax for chest excursion, we use the palmar surface of our hands, and to determine tenderness, we use either the finger pads or the palmar surface. And we'll be going over this during the respiratory assessment. So abnormal or adventitious, as they're also called, lung sounds include crackles, which are discontinuous, meaning you're going to hear them on inspiration. They're like wet sounding. They kind of sound like Rice Krispies. If you take your hair and put it like over your ear and rub your hair between your fingers, that's kind of like what they sound like. It could mean that your patient has atelectasis, or it could mean something a little more dire, like your patient is going into pulmonary edema. Wheezes is indicative of like air moving through a restricted airway. So think asthma, COPD. Um, they can be on inspiration, expiration, um, and they could have mucus involved as well. If you have low pitch wheezing with that's called bronchi, usually you'll hear that in the bronchial areas, and it may clear with coughing. There is also something called stridor, which is high pitched crowing sound that you can hear without a stethoscope. Okay, and that is indicative of inflammation and obstruction, and it's a medical emergency. So you would call a rapid, okay, for that. And then if somebody has a friction rub, a pleural friction rub, that means there's inflammation between the pleura, and that sounds like scratching two pieces of leather together. For cardiovascular assessment, remember we've already inspected the chest. So you want to compare the apical pulse with the radial pulse. You want to assess heart sounds in all areas. I'm going to show you that on another slide, the areas you need to listen to. You're going to first listen in each area with the diaphragm, and then you're going to use the bell in each area. Okay, so you would do each area with the diaphragm, then each area with the bell. And when you use a bell, you don't hold it down. You have to like just kind of rest it on the chest so that you can hear. And then you're going to check capillary refill in the extremities, and it should be less than 3 seconds. You want to check and document edema. I have another slide to explain how to do that. And you want to be able to palpate the posterior tibitalis and the dorsal pedis pulse. And I have another slide that's going to show you where those pulses are. If you cannot palpate a pulse, you need to get a Doppler and check with the Doppler. Assessing for a pulse deficit is done on a patient that is perhaps having a dysrhythmia or having palpitations. It takes 2 nurses, and one nurse counts the apical pulse for 1 minute, and one nurse counts the radial pulse for 1 minute. If your patient is having, like, say, for example, AFib, they may have what's called a pulse deficit, meaning not every heartbeat is perfusing to the peripheral pulses. Okay, so your radial pulse will be lower than your apical pulse. It takes 2 nurses to do it, and you have to count for 1 minute. Now you need to auscultate in at least these 4 areas I'm going to present to you. The aortic area is at the second right intercostal space at the sternal border. The pulmonic area is at the second left intercostal space at the sternal border. The tricuspid area is at the fourth left intercostal space at the sternal border. And finally, the mitral area, which is also where you're going to take an apical pulse, and also where the point of maximal impulse is, where you would palpate that. The mitral area is at the fifth left intercostal space at the mid-clavicular line. The normal heart sounds are S1 and S2, the lub-dub. So S1 indicates that the tricuspid and mitral valves are closing, and it is the beginning of systole. So that's S1. S2 is the dub, and it is the end of systole or the beginning of diastole. So just remember, the dub is for diastole, and it indicates when the aortic and pulmonic valves are closing. To palpate blood vessels, you are going to use either the finger pads of your hand or the palmar surface of your hand. So an example of using your finger pads is when you're taking a pulse or palpating distal pulses like in the lower extremities. So we always want to know the rate and rhythm. And rhythm means, is it regular or irregular? The rate is you're going to count a pulse, right? And then the amplitude means the strength of the pulse. So a normal amplitude is +2. So anything less than +2, you're going to be concerned that there's low blood flow, something's going on. If it's greater than +2, it could indicate certain things, for example, like fluid volume overload. That, we call that a bounding pulse. We call a pulse less than +2 thready. So you might see that in somebody with fluid volume deficit. If you cannot feel a distal pulse, in other words, a pulse in the posterior tibitalis area or the dorsus pedis area, which is on your ankle and foot, and I know you haven't been taught this yet, you're going to need to get a Doppler and see if you can hear it via ultrasound. Please review the peripheral pulses and where you would assess peripheral pulses. If you are unable to palpate a peripheral pulse, please get a Doppler and figure out if there's perfusion before calling the provider, because that'll be good information to give the provider when you call. Super important that you know how to document pitting edema. In a lot of conditions we talked about this semester, you are going to be documenting pitting edema, like in hypernatremia, congestive heart failure, those kind of conditions. Somebody with venous insufficiency could have pitting edema. So basically, you evaluate the skin by pressing down with your thumb or your finger over a bony prominence, like usually the ankle, the tibia, so like in the lower extremity usually. And the depth of the edema reflects the degree of edema. So if you have grade 0 edema, that means they have no edema. If you have +1, that's trace. Okay, you have to know the severity, trace edema, pitting edema, and it'll be 2 millimeters. And it's a rapid skin response, meaning when I press the edema, it goes to 2 millimeters and it recoils rapidly. When we get to grade 2, okay, it's going to be mild edema, considered mild edema, and there'll be a 4 millimeter indentation, and it's going to take 10 to 15 seconds to recoil back the skin. +3 equals moderate, and the skin will indent to 6 millimeters, and there'll be a prolonged skin response, meaning it'll take longer to recoil back to normal than +2 and +1. And then finally, +4 is severe, and it will indent to 8 millimeters, and so you'll have a prolonged skin response. Now, with all of these, all you have to do with the grade is multiply it by 2, and you will get the amount of millimeters of the indentation. For example, look at grade 1 times 2 equals a 2 millimeter indentation. Grade 2 times 2 equals a 4 millimeter indentation. Grade 3 times 2 equals 6 millimeters of indentation. Grade 4 times 2 equals 8 millimeters of indentation. So that's a little trick that can help you. For skin assessment, we're going to use inspection and palpation primarily when we're assessing skin. We also, when we assess skin, we document or note any dressings, IVs, any types of lines the patient may have. Skin inspection. Every time you go to a different area of the body, you inspect the skin in that area. And you inspect the skin for color, moisture, vascularity, edema, which means swelling, and lesions. And a lesion is just a broad term that describes any unusual finding. Normally the skin is without lesions, but a lesion could be a bruise, it could be a mole, it could be a skin tear, it could be a pressure ulcer, it could be an insect bite. Lesion just means something that shouldn't be there is present on the skin. When you palpate, you're going to use different parts of your hand to detect different characteristics. For example, when you're palpating the skin, to determine the temperature of the skin, you're going to use the dorsum of your hand, which means the back side of your hand. When you are assessing for moisture, texture, or thickness, you're going to use the palmar surface of your hand. When we test for skin turgor, we grasp the skin with our fingertips. It's a pinching motion. And to determine tenderness, we palpate with finger pads or the palmar surface. Talked about abdominal assessment above, so check out that. You're mostly going to do inspection and auscultation, probably not palpation every time. It's certainly not percussion, okay? You want to, make sure you inspect and listen to the bowel sounds as I described above. You want to check any tubes for drainage and also skin integrity. Also, if they have a stoma, you want to check the stoma and make sure it is pink, shiny, and moist. You want to also inquire if they're passing flatus. Passing flatus is the gold standard that indicates that patients have resumed peristalsis, like after surgery or an obstruction. Okay, so that's really important. And ask about last bowel movement. Know your client's diet and know how your client is tolerating it. With gentle urinary assessment, You want to inquire the patient if they are voiding regularly. You're going to check urine for clarity and color. And if the urinary output is less than 30 mLs per hour, you're going to do a bladder scan. You need to determine if the low urine output is due to the production of urine, like the making of urine, or is the patient having some type of urinary retention. A bladder scanner is a non-invasive ultrasound which helps measure bladder volume and residuals of urine in the bladder after urination. So the bladder scanner is good because in the old days when we didn't have bladder scanners, oftentimes like after surgery, a patient gets their Foley DC, they have to void within 6 to 8 hours. And even if they didn't have a Foley, somebody after anesthesia has to void within 6 to 8 hours. And so if they don't, we used to straight cath them right away to see how much urine was in there. Well, the bladder scanner lets us know if there's urine in the bladder. So what I'm trying to say is we don't necessarily have to straight cath them if it doesn't look like there's a lot of urine in the bladder.